Hello and welcome everyone to today's webinar, Policy Measures on Drug Value. Does ICER's approach improve patient access and equity? I'm Gunnar Esiason. I'm a patient advocate and rare disease patient leader living with cystic fibrosis. Professionally, I serve as the Director of Patient Outreach for the Boomer Esiason Foundation, which has raised more than $160 million in the fight against cystic fibrosis. I will be your moderator for today's event. First, I would like to thank our host organizations, Pioneer Institute and the Pacific Research Institute, for organizing the event and being leaders on healthcare and other public policy issues, including patient treatment access and health equity. On behalf of the Pioneer Institute and the Pacific Research Institute, I would also like to thank all of our guest speakers for participating in today's program, all of whom are experts in their fields and on the issue of drug value and ICER. Lastly, I want to thank all of our live and on-demand viewers for joining us for today's event and taking time to understand the policy landscape on treatment value and what that means for patients. Before we begin our official program, I want to take a brief moment to introduce our speakers and set the stage for why we're here today and what we will cover. We're honored to have several healthcare policy and advocacy experts with us for today's discussion who will share their perspectives on ICER, equity, and patient access issues. They include Dr. Bill Smith of the Pioneer Institute, Weingarten of the Pacific Research Institute, Dr. Gary Puckering of the National Minority Quality Forum, and finally, Anna Hyde of the Arthritis Foundation. Thank you all for taking time today to share your thoughts and ideas. Before we begin our discussion, I want to remind all of us why we are here today. In 2021, President Biden, Congress, and state legislators have again put a magnifying glass on efforts to improve prescription drug affordability and access for patients. More often, lawmakers in Washington and states are looking to the Institute for Clinical and Economic Review, or ICER, to determine drug access and pricing decisions. ICER is best known for the reports they produce on the value of individual treatments. Those reports essentially make a recommendation for whether the drug is worth the price associated with it and whether it should be covered from a budgetary perspective. Personally, I've written about their reports at length in my own blog and in a number of opinion columns. So I'm excited to hear what our panelists have to say today. The first question is this: should policymakers use ICER recommendations to determine drug prices and access? The second question: what impact do ICER's recommendations have on patients and broader access issues? For the next hour, our panelists will explore the policy landscape on drug value and how policy proposals that lean on ICER and similar approaches could impact certain patient communities. Just a friendly reminder for our live audiences before we begin our official program. Everyone on today's webinar is in listen mode only, but you can use the Zoom chat feature to submit questions to our presenters during the discussion, and we will have a question and answer session at the end of the program. With that, let's just jump right into it. Our first presenter today will be Dr. Bill Smith, a visiting fellow in life sciences at the Boston-based Pioneer Institute. Bill regularly conducts research and analysis on issues relevant to ICER and the Quality Adjusted Life Year, or QALY, methodology and its impact on vulnerable patient populations. Specifically, Bill has published individual reports that demonstrate how ICER would impact patients with a rare disease, disability communities, and those living with cancer. Prior to his time at Pioneer, Bill held senior staff positions on Capitol Hill and the White House and the White House Office of National Drug Control Policy. As a starting point, Bill will provide a brief background on the quality methodology that ICER uses to determine the cost effectiveness of treatments. Bill, thank you again to Pioneer for hosting. The floor is all yours.
Thank you, Gunnar. Appreciate it. Welcome to everyone. As Gunnar said, the most important term to define in this discussion is the Quality Adjusted Life Year, so-called QALY, which is the methodology used by ICER, and it's also used by many European healthcare systems. It was invented in Great Britain to rate the value of different therapies. Initially, they thought they were going to rate every healthcare therapy, from hip replacements to drugs, but the QALY has largely devolved into a system for rating drug therapies, and it's used exclusively by ICER to rate drug therapies, no other treatments. And the quality, I'm going to discuss it, define it at 30,000 feet. I'm not going to go into all the different aspects of the methodology because it can be complex, but I hope I can explain the core of what's going on. So the quality rates drug therapies according to their ability to do two things. One, to extend a patient's life. So a drug that's going to extend a patient's life by 50 years is going to get a high rating. But equally weighted with longevity is quality of life. Is the drug going to improve the quality of life for the patient? Is it going to reduce their pain, or is it going to give them pain? So it will get two scores, one for longevity and one for quality of life, and those scores will be mixed into one rating. And importantly, you should understand they monetize this. So the way they monetize this is they say, okay, what is the value of a year of life lived in perfect health? Perfect quality of life and 1 full year of life. What is the value of that? And ICER roughly comes in at about $150,000. They say a year of life lived in good health is worth about $150,000. And then they back a suggested drug price into that based on the therapy's rating. So if a therapy only extends your life for a month and it gives you quality of life problems, it's going to get a very low rating, and the threshold price for that drug is going to come way down from the 150,000. On the other hand, if it extends your life by 50 years and cures all your quality of life problems, it's going to get a high rating, and the threshold may be higher than 150,000 for that drug. So that's how they monetize it. And I just want to suggest, however, that the 150,000 is a little bit of a subjective threshold. I mean, I don't know where that comes from. You know, when it comes to one of my own children, for example, I would say a year of their life lived in good health is worth millions of dollars. And in that case, almost every drug therapy would be rated as cost effective. And some people may take the opposing position and say, well, you know what, a year of life is only worth $10,000. And in that case, very few drug therapies are going to be rated at that level, rated cost effective. So the $150,000 threshold, in my view, was chosen because most drug therapies that are rated by ICER are going to be rated as not cost effective, and they're going to come in with the suggested price below whatever the drug company price is. And that's their goal, is to say, and they say this publicly, drug prices are too high. Our job is to correctly value them at a lower price. And that's generally what they do. Now, you may have an issue with the threshold or other, but a lot of people say, oh, you know, this is common sense. If a drug extends people's lives and makes their lives better, why wouldn't it be rated that way? Isn't that a common sense way to rate drugs? And as a former Capitol Hill staffer, and we may have some on the call today, I bet you come into many situations in which you see a bill that sounds wonderful in the abstract, but when it's thrown out there into the population, it has all sorts of adverse consequences that not everybody thought out. And I would argue that that's the case with the quality. So I'm going to just look at 4 patient populations that might be adversely impacted by the quality and why. So older Americans, say you're a patient who is 60 years old and a drug is invented and it's going to get you to 80, and you're thrilled about that. You had a condition where you would have been died earlier. There's another patient with a different condition who's only 30 years old, and that patient is going to pass away earlier than he would have ordinarily, and a drug is invented that gets him to 80. So it gets him 50 life years. The 60-year-old patient only gets 20 life years. So the drug for the younger person is going to be more highly rated under the quality methodology because it provides more life years. Say neither patient has quality of life issues, so that's not a factor. So it's 50 life years versus 20 life years. The drug for the younger person is going to be rated more highly. Now you may say, oh, that drug is more beneficial. It's taking a young person and preventing them from dying young, and maybe that's true, but I'm not sure older people would agree with that. Everybody wants to live to 80 or older. So that's one problematic aspect. Another group that has problematic consequences for the quality are people living with disabilities. So say you're a disabled person, you're non-ambulatory, you can't get out of a wheelchair, you have struggled moving around, but a drug is invented for your condition that gets you 20 more years of life. Doesn't solve your quality of life issues, but it gets you 20 more years of life. There's another patient who doesn't really have disability issues, maybe modest quality of life issues due to their condition. A drug is invented for them, gets them 20 more years of life. that drug is going to be more highly rated than the drug for the person living with disabilities because it solves the quality of life issues and gets 20 years of life, where the drug for the disabled person does not solve the quality of life issues. That's problematic. And some people would even say that's a violation of the Americans with Disabilities Act, because you can't, the person living with disabilities deserves 20 years of life as much as the person living without disabilities, and would say that there should be no difference between the prices of these drugs. So a third population, and this goes back to the threshold issue of $150,000 for a year of life lived in full health. Rare disease drugs, as anyone economist will tell you, are going to be more expensive than others. We can argue about individual cases where you may say, oh, that company's price gouging. But the bottom line is, if you're as a biotech company spends $500 million on R&D, and they're solving or curing a disease where there's only 5,000 patients, that drug is going to be quite expensive. That's just the reality. We can argue individual cases, but as a general rule, those drugs are going to be more expensive. And given the economics of rare disease drugs, that $150,000 threshold isn't even close to what you would need to say that a gene therapy, for example, that cures sickle cell disease is going to be cost effective. And what we found in ICER reviews is that almost no rare disease drugs get a cost effectiveness rating, a superior cost effectiveness rating. It just doesn't happen in ICER. And it's largely because these thresholds are so low, they don't take into account the economics of rare diseases. And finally, let me conclude by talking about people living with cancer. Now, I wrote a paper on this, and it's available on the Pioneer Institute website. And there are many, many problematic aspects to using the QALY to rate cancer therapies. But let me just mention two important ones. One, caregivers. Cancer is a condition where patients require a great deal of caregiving in many situations. So one study that I read recently said the average amount of time a caregiver gives to a patient is 32.9 hours a week. So many caregivers, a spouse, a relative, a daughter, a son, maybe even have to go part-time or give up their job to care for a patient. So what if a drug therapy comes along that improves the quality of life for that cancer patient so much that they can perform their own tasks of daily living and don't need very many hours of caregiving? Isn't that a value? It is a value in my view, but that value is not factored into the cost of the drug. It doesn't allow the drug to be more expensive because it might save on average $30,000 in caregiver costs. ICER just doesn't include that. And I don't know why. Caregivers are so important, and the economic sacrifices they make for the patient are so important. Why would you not factor that in to your model? The second problematic aspect, and there are more, is the clinical trials. Cancer is the therapeutic area where the patients in the clinical trials are most unrepresentative of the patient population that will actually take the drug. That's for a variety of reasons. There may be inclusion criteria in the clinical trial that limits the type of patient that can join. It also is related to the fact that in oncology, many drugs are prescribed off-label later. So the drug may get through clinical trials with approval for lung cancer, but an oncologist may discover it works well on colon cancer and prescribe it to a colon cancer patient. So the problem with that from an ICER review perspective is that the ICER's done the review based on the clinical trial data. And that the clinical trial data doesn't represent the types of patients that are going to be using it. You know, if oncologists discover a year after the drug's approval that it works really effectively on colon cancer, a non-indication, ICER's review doesn't take that into account, and that's problematic. You know, again, I want to point you to the paper that I wrote on cancer and QALYs, because Great Britain had quite an experience with this. They used QALYs to rate cancer therapies for a couple decades, and Parliament woke up one day about a decade ago and discovered Britain had the worst cancer care quality in the developed world. And Parliament just went crazy, and there were patients with breast cancer marching on Parliament because they were denying all sorts of cutting edge drugs that were coming out. And the politicians, David Cameron was the prime minister at the time, and the Conservative Party in Parliament said, enough is enough. We are banning the use of QALYs in rating cancer therapies. And they banned them. And I tell that story in the paper in Pioneer. And I would warn politicians on Capitol Hill and elsewhere that want to embrace some of these cost-effectiveness methodologies, that they may want to read up on what happened in Great Britain, because there was a political firestorm about the access limitations that were placed on cancer therapies. And we seem to be going in that direction in the United States, and that's a problem for me. So with that, I'll turn it back to Gunnar and look forward to the Q&A.
Thanks, Bill. I especially appreciate your comments on the tax on caregivers, especially when it comes to complex medical conditions. I know that's something that my family has faced head on throughout my life with cystic fibrosis. Our next presenter this afternoon is Wayne Weingarten, a senior fellow in business and economics at the Pacific Research Institute and the director of the PRI Center for Medical Economics and Innovation. Wayne's research regularly explores the impact of fiscal policy, the healthcare industry, and drug value frameworks. Wayne has written multiple briefs that touch on ICER and innovation issues and is a regular contributor to Forbes. Thank you for joining us, Wayne. I'll let you take it from here.
Thanks so much, Gunnar, and it's great to be here with everyone. And I'm listening to Bill talk, and when I'm thinking to myself as he's talking, and he does such a wonderful job talking about all the problems with the QALYs, and those problems alone, I think, raise a lot of questions about the value of ICERs models and their framework. Unfortunately, that's far from the only problem that ICER models have. And I think it's very important for us to understand it, because the influence of ICER continues to grow, and the influence of these value assessment frameworks that they rely on and the cost effectiveness models are continuing to be used, and they're continuing to be assessed with value. The idea that ICER is sitting up in Boston and able to determine the value of drugs for 300 million Americans across hundreds of disease areas, and the point of they are unable to do that, right? And I think it's very important to understand that what ICER is doing is they're estimating price controls. They're not actually quantifying value. And the reason why they're doing that, and I'd like to touch on a number of the flaws, you can look in and kind of divide them into kind of fundamental flaws of kind of the approach, and then some of the methods that they're using and the errors in those methods, as well as some implementation problems and some of those that Bill touched upon that I'd like to emphasize. But I think from a kind of a fundamental perspective, one of the largest problems is the sheer number of assumptions that ICER is making in order to run their cost effectiveness models. Right? They have these reports, they're very thick, and they have all of these complex models, but ultimately what you begin with are assumptions. And these assumptions, they're the judgment of ICER, but importantly, if you change the assumptions, you're going to change the outcomes. And this is some of the things that Bill was talking about with the QALY, but there's many other aspects to it. And so what you actually have then is a subjective analysis. And that subjectivity means that it's a price control, right? Because there's no objective truth to the kind of the foundation to what ICER is doing. And in effect, they have these complex models that in effect hide that inherent subjectivity of the models. And that inherent subjectivity is creating price controls from a private organization, but controls nonetheless. The other kind of, I think, fundamental flaw that's within this entire approach is this idea that by imposing price controls, we're creating access. And the data, when you look internationally, to completely dispute that. If you look at access to medicines, here in the US, we have access to nearly 90% of all the new innovative medicines that have been introduced over the last decade. Whereas if you look at the HR3 countries, right, the ones that we're going to price benchmark ourselves to, they only have access to about half of them. Now, how you benchmark to prices to medicines that don't exist, I don't know how you achieve that, but that difference in between access that the US has without price controls and access in countries, France, United Kingdom, Canada, that all impose price controls, I think it demonstrates the basic fallacy that this approach that we're going down with ICER is actually going to improve access, because what the data show is that they don't. we're going to actually begin to limit access if we continue to go down that road. Some other, I guess, methodological errors that ICER is conducting, in addition to qualities, are important to understand, because even if somehow ICER resolved the quality problem, the models still are not valid. And I think one of the more important errors that they're making, and this is in a piece that we published at Pacific Research Institute, it's on our Center for Medical Economics and Innovation website, the error is this population perspective that they're taking. And it's very odd, because right now in medicine, many of the improvements we're gaining are from personalized medicine, right? We're trying to get medicine as personalized as possible, and our ability to address so many diseases is improving because of that. The entire ICER approach is a population perspective. We're looking at the average benefits, at the average costs, and we're trying to take these population averages and try to determine what's that value for an individual patient. And there's just an inherent tension. And what's interesting is ICER notes those flaws. If you look at their value assessment frameworks, they'll say there's an inherent tension between the uniqueness of patients and kind of these population perspectives, but they note it and then basically ignore it. But the bottom line is that the value of a medicine is going to be inseparable from a patient's individualized, how effective is that for me? What type of side effects am I having? Other medications I'm taking, other conditions, allergies. I mean, it goes on. And all of that requires a personalized framework to understand the value. Since ICER is taking a population perspective, by definition, that perspective is going to be implementing price controls. And I think that's why it's important to associate with what they're doing is price controls. They also have, and this is directly controlling prices, a very subjective budget constraint. What they're basically arguing is that our expenditures on medicines should grow at the rate of our economy, right? At the rate of GDP plus 1%. Why plus 1%? I guess it's bigger than the economy, so that sounds like it's generous, but in reality, why GDP plus 1%? Why isn't the budget constraint connected to our demographics, right? We have an aging population. More people are 65 and older than ever, and that's going to continue to increase with the baby boom generation. So why wouldn't you connect your budget constraint to demographic changes? Or why not, connect it to your impact on net costs? They say they do, but in reality, they're failing that. If I have a medicine that increases expenditures on drugs, GDP plus 3%, but it halves my expenditures in hospitals, that actually, from a healthcare perspective, is a good trade-off. All of these types of kind of important impacts are excluded from the ICER framework. And these are many of the essential kind of ways that we come up with how do you understand the value of a medicine. Just as importantly, in the past 3-4 years, prices, we're not looking at the list price, looking at the net price of medicine, right? When you include all the discounts, have been going down. So their budget constraint, their budget framework is actually assuming that expenditures should go up every year, when in fact that isn't always the case. And so we want the ability to see prices decline, which is you see in many other markets, not just increase. All of this perspective is brought out. And so what you're actually imposing is not just kind of a cap on prices, but also a floor, so that we're going to, in effect, mandate prices of and expenditures of medicines grow at that GDP plus 1%. Again, a subjective arbitrary assumption that is moving the prices of drugs further and further away from what is actually value. That's what they're claiming to do. That's what we actually need. We're getting further away from that. A third flaw, and this is something I don't think that gets enough attention, is this evidence ratings matrix. They use it, what they call evidence ratings matrix, and they assign a letter grade where, we've all been to school. So A is better than a B, C, D, or you can get an I, which is inconclusive. Mind you, many reports you end up with an I simply exactly for what Bill had said, that you're doing these reviews of drugs during the clinical trials, or just when the clinical trials have finished. So there's not enough evidence of what the impact is, especially when you're talking about drugs that are impacting people's health over the long term. But what you actually have there with the evidence ratings matrix, right? Our understanding of the impact of the drugs comes from clinical trials, and it comes from post-marketing studies. And in fact, the FDA says that the post-marketing studies are incredibly important for understanding what the impacts are. Precisely what Bill was talking about, that over time we learn so much, you can only know a certain amount of information at the clinical trial stage. ICER is not running these clinical trials, nor is ICER running a post-marketing study, right? What they have is an opaque methodology. We don't understand what it is. They've invented it. It's not reproducible. Bill and I couldn't sit down, do their evidence ratings matrix methodology, and come up with their A, B, or C, nor can we understand why truly they've had that rating. It's an arbitrary, opaque methodology where they're getting in the way of the judgment of doctors and the judgment of healthcare providers. And they're stating that we believe that the strength of evidence is not there. Why? We don't know. Why they should be making that decision as opposed to the doctors or again, that personalized healthcare. They're separating, again, it's a further separation from where value is really determined, which is that personalized patient-driven healthcare. A fourth, and I won't go into this because Bill did such an excellent job, but a fourth problem is equality. I guess the one thing I would add to it is there's a new measure that ICER has brought in. It's got the elegant name of an EVLYG. It's an equal value life year gained. It's supposed to get into or address the idea that what is perfect health, and instead of trying to define perfect health, the EVLYG says one person living 1 year is all equal. It doesn't address the vast majority of the problems that Bill raised. And so that this additional measure, which is supposedly a fix for the quality, is in effect just falls for the same problems. And so that this basic approach that we're taking is the fundamental problem, not simply the quality adjusted life year. I would, I guess, end with the idea that the timing of the reports and that the non-healthcare benefits, both of which that Bill addressed, are other important implementation errors, that the ability for them to actually make those judgments is, again, arbitrary, subjective, and it leaves patients out of the equation. What's important to patients that is going to vary from disease area, age group, all of these individualized important considerations that when they're implementing it, they're not given adequate consideration. And so what's truly important for patients, it's not necessarily always going to be left out, but there's always that possibility, which again leaves too many patient groups vulnerable to their subjective assessments. I guess I would end with the idea that the consequences from following these analyses is large. So it's not that this is some sort of academic exercise that's not going to have real impacts. What we're actually doing is reducing health outcomes from patients, reducing the incentive for innovation, creating higher costs and more access restrictions. And because of that, it's incredibly important for us to fully understand what is happening. The fact that they're not estimating value, what they're doing is imposing price controls, and that we need to go into that with our eyes open. With that, I'd like to turn it back to Gunnar.
Thanks, Wayne, and thank you for your perspective. I especially appreciate your comments on the subjectivity as they relate to some of the seemingly rigid assumptions that ICER is making at the base of their models. But thank you again. So joining us next, we have Dr. Gary Puckering, the president and CEO of the National Minority Quality Forum. The forum works across healthcare issues to eliminate the disproportionate burden of premature death and preventable illness for racial and ethnic minorities and other special populations. In September 2020, the forum published a white paper that demonstrated how traditional value assessment frameworks fail communities of color and exacerbate health inequities. Dr. Puckering, thank you for being with us today to share your perspective. The floor is now yours.
Thank you so much. It's a great honor and privilege to be part of this conversation. I would start the conversation really with a question. And the question is, so what do you believe is the purpose of our healthcare system? something you should think about for a moment. What is its purpose? Some people would say that our healthcare system delivers the care that you can afford. So if you can afford it, you can get any care you'd like. Some would say that, well, we can't take care of everyone, and so we need to ration care, and we need to come up with these models to ration care. We at the National Minority Quality Forum believes that the purpose of the healthcare system is to lower patients' risk, lower their risk for going to the hospital, lower their risk for disability, lower their risk for mortality, while improving the quality of their life. When you start with that premise, first of all, we think that that idea brings us closer to our social contract. We actually have a social contract that is the essence of the American experience. And that's what it says is life, liberty, and the pursuit of happiness. Actually, the original language was conservation of life, that we all came together in a great collaboration to support conservation of life, and in the process of doing that, giving ourselves as much freedom and much happiness as possible. The problem with ICER and value assessments and all those is that they're not about patient risks. In fact, if you look at any of their formulation, there's no place that they talk about what happens to patients when you don't give them access to quality care, when you withhold medications. Take a look at hepatitis C. We've actually have a cure for hepatitis C. ICER says that it's not a value to do that. So right now, 14,000 people die every year from hepatitis C when we could actually cure it, right? The other thing that we don't consider when we talk about these value assessments is that we're thinking of value in the moment the care was delivered. But what we lose is the long-term investment that we're making in healthcare. What we want to do, right, is that we want to get rid of these diseases that plague us. Right now, as I said, with hepatitis C, we've had cures. If you look at cardiovascular disease, the trend lines are moving downward, even with cancer, although we have a long way to go. The trend line is moving downward. Those are investments that we're making. Same kind of investments that DOD makes in the Air Force and the Navy. Nobody complains about the price of those investments or the investment that we made in the internet, et cetera. ICER actually breeds inequality. There is no way, absolutely no way, to eliminate inequities in the American healthcare system using the ICER model. It necessarily wants to ration care. That's its purpose. Its whole purpose is to put a value on life and say that there's some life that it ain't worth paying for, right? And the whole idea with ICER is that fundamentally what we're really talking about is what care should we pay for our neighbor, right? Because we know what care we want for ourselves, but this is a conversation about what care do we want to give to our neighbor. And I would say we all need to start with the fundamental premise. The purpose of our healthcare system, its only purpose, is to mitigate risk, to help people stay out of the hospital, to help people stay out of the emergency room, to help people stay away from disabilities while we improve the quality of their life. There isn't anything else it's supposed to do. When it does anything else, when it subordinates any of those premises, right, then it's necessarily going to elevate risk. And the minute it does that, it's doing harm. And that kind of harm needs to be reportable, right? So if ICER wants to do value assessments in which it wants to ration care and say that some people ought not to get these medications, because if you can buy it, you can go get it. But we're really talking about healthcare that we have to pay for through insurance, and poor people and others to have access to it. So if we want to do that, we also need to talk about the patient risk. They also need to report on what happens to those people who we deny quality care for. Do they go to the hospital? Do they become disabled? Do they die? What happens to the quality of their life when you withhold care? ICER wants to talk about quality of life against medications, but it doesn't want to talk about quality of life when you withhold care. And that's really the fundamental problem here. So we don't spend a lot of energy going through all of the traps and methodologies and systems and new language and all of that stuff that ICER creates, because we understand they have a different purpose than we have. And so when you start with the purpose that you want to mitigate risk, it takes you down a whole different pathway. And I would argue our society has the capacity to do that. But even more fundamentally, that's why we came together. That's what our social contract is about. It is not about leaving some people out. It's not about rationing provisions to say some people ought to get and others should not because we can't afford them. There's nowhere in our social contract that we ever agree to that. So for legislators and policymakers, I would argue that messing and mucking around with value assessments and ICER is a breach of our social contract. You have a responsibility to your constituents. And in healthcare these days, healthcare policy is like medicine. If you deny access, you're going to have the same application as not giving someone medicines or giving them bad medicines. And so you have to understand what your job is. And your job is to help us all mitigate risk. There is nothing else that our healthcare system is designed and built to do but to do that. And we at the National Minority Quality Forum are deeply committed to those principles. I'll turn it back to Gunnar.
Thanks, Dr. Puckering. That was excellent. We appreciate you sharing your unique perspective here. And I especially appreciate your comments on rationing care, which especially feel timely given the last year and a half that we've all had to live through, especially when hospitals are being overrun across the country or were last spring. To conclude today's official program, we have Anna Hyde with us. Anna is the Vice President of Advocacy and Access at the Arthritis Foundation, where she oversees federal and state legislative programs and grassroots engagement. Anna is recognized for her work advocating on complex healthcare policy and advocacy issues, and ICER is no exception to that. We're excited to have you with us today, Anna. The floor is now yours.
Thanks for having me. I appreciate the opportunity. So my goal is to take this down to more of a kind of 500-foot level and talk about our experience working through value assessment. We've worked with ICER on a couple of different reviews of arthritis drugs. So I kind of want to just talk about our experience doing that, and then just sort of building on some of the themes that have already been talked about, and then really start to talk about some sort of solutions for forward thinking. So I'm going to start with our just general experience working in 2017, 2016 into 2017. We were, I think, one of the first therapeutic areas that ICER worked with in this way. So it was kind of an interesting experience. That the headline really is that we were very consistently engaged throughout the process, and both in informal and formal ways. I think that our engagement had a big impact on the final report. One of the most important things that we did was to conduct a survey of our patient population and their experiences with the 11 biologic drugs that are indicated for RA. So it was 11 drugs that were part of this review. And we got some really interesting highlights from that data that I think really helped to inform the report and that we have used since. So just a handful of the highlights are that a majority of patients cycle over several medications over the course of their disease and often change medications early in their disease treatment, which we knew from a lot of anecdotal evidence and certainly from engaging a lot with healthcare providers, but having the data points was, I think, really valuable. That it's not just you're going to find one drug that is going to work for you and then you're good for the rest of your life. It's not like that. And so, that I think was one of the most important data points. A lot of our patients have to overcome significant systemic barriers in order to receive their medication. And you've heard some of that already, but that can be, the administrative burden. We've certainly heard patients talk about it being almost as burdensome as the disease itself, and they liken it to a full-time job often. And oftentimes, people with arthritis receive more medications for pain and depression and other comorbidities, and therefore they accrue additional costs to the system, especially when their RA is not well controlled. So for us, it's all about finding that stability. And when you find a drug that is going to work for you and that is working for you, the ability to stay on that drug. So those were some of the highlights from our data. And then based on that report, what we saw in the final ICER report was recommendations to streamline and reduce prior authorization and step therapy requirements, which we thought was important. They recommended allowing patients who are stable on an effective treatment to remain on the therapy if their insurer changes, something we've long advocated for, improving rebate negotiations and shared savings for patients, which we've also advocated for a long time. And that, in particular, one that we carry forward often is that step therapy is not appropriate in all cases. So in that sense, if we saw payers adopting a lot of the recommendations from the ICER report, it may follow that utilization management would be more streamlined and patients could have better, easier access to the drugs. However, on the other side, that it's that reliance on the quality threshold, where if payers adopted the recommendations wholesale, basically no RA drug would be on formulary because they all surpass that $150,000 threshold. So it's a very mixed bag in that sense, and I just kind of wanted to present both sides of that coin. So I think that's sort of a good segue into some of our concerns about methodology generally. This isn't all specific to ICER. I think a lot of it is indicative of problems with value assessment that are broader, that are indicative of broader problems in the system. And we've certainly talked a lot about the quality already, so I'm not going to say much about that, except that it's very personal to the arthritis community, because there are quality measures that have rated inflammatory arthritis as a condition worse than death. And I think that people with arthritis would take issue with that assessment. So that's sort of our objection to the quality, I think it can be summed up there. Some other just things that have come up to the top as we've engaged more and more in the area of value assessment over the last few years, certainly issues with clinical trial data not being fully representative and not taking into account heterogeneity of disease, which is true in so many of our therapeutic areas. And therefore, it's not sufficient to capture the full scope of how treatments will work in patients, what costs are borne to the patient and to the healthcare system when a drug doesn't work, or if a patient can't access the drug that they need. Real world evidence is an issue. There's not really a robust collection of real world evidence in the system at the moment, which is really essential to measuring true efficacy and value of treatments. ICER has recognized the importance of real world evidence in its previous value frameworks, but systemically, there's not a current standard to collect real world evidence just across the ecosystem. So that's an issue. You see data captured through registries, patient surveys, payer claims data, but there's not really a standard aggregated place to really see what's going on with clinical outcomes. And then budget horizons are another issue. This has been touched upon as well, but for chronic diseases, you're looking at lifelong care. So looking at a 5-year or even 10-year budget cycle isn't really going to capture what your value and outcomes that matter to you. We're not just talking about, whether you're going to be stable on your drug for the next year. We're talking about trying to keep you out of the hospital and keep you from having to get that joint replacement or whatever it may be down the line. And we're talking about sort of total cost of care, lifetime cost of care, which are really important, if you're looking at value in a holistic way, which we certainly do. And And then this has also been touched on, so I don't want to go too far into it, but just patient outcomes preferences and contextual considerations. Again, ICER has made improvements here and talked in their value assessment frameworks about the importance of contextual considerations, but we're still lacking a really standardized way, to capture that and really an agreed upon sort of consensus for how to capture that kind of data. But truly, I mean, in a patient-centered healthcare system, capturing the outcomes and preferences that matter to patients is critical, and we don't feel that it's adequately reflected currently. So why all this matters? Obviously, it's all about patient access. I talked a little bit about this before, but we've seen examples of payers talking about formulary restrictions for drugs that do go over that $150,000 threshold. And as I mentioned before, all 11 drugs in the 2017 ICER review would surpass that threshold. So that's obviously a problem. And then increasingly, policymakers are looking at how to deal with the issue of drug prices and just overall, costs in the system. So we're seeing that at the state level, certainly with state legislation. We're seeing it federally, both in Congress and with the administration. We've heard a little bit already about international pricing models and things like that rely on the quality. So I don't need to go into that, but these are all things that we are concerned about and looking at. And ultimately what we're looking for are solutions. How do we move beyond the quality? And how do we inject more transparency into the system overall? So this certainly goes beyond ICER, and it goes beyond any of us here. So really sort of working towards a more coordinated approach to address the problems and create some standards around real world evidence, value to the patient, those sorts of things. And we know that there are areas of consensus around the value of value-based healthcare, value-based care arrangements, things like that, that we would want to see more of tested and scaled and those sorts of things. So I'll stop there because I know we might get into this a little bit more with the Q&A, but Gunnar, I'll turn it back over to you.
Thanks, Anna, and I will keep my comments here short before we jump into the Q&A. But in our time remaining, we'll open it now for some question and answer sessions. And as a reminder, you can ask questions in the chat feature of the Zoom webinar under the Q&A tab at the bottom of your screen. So now we're just going to jump right into the first one here, and I'll open this one to any of the panelist members who want to go for it. But Bridget asks, what are your thoughts on ICER saying it is open to getting away from quality if it's making policymakers uncomfortable?
Yes, I'll jump in terms of whether it's making policymakers uncomfortable. I think we need to be careful in terms of adjustments to it, because what we really need to do is get away from the concept of trying to quantify the quality of somebody's life from kind of that centralized organization. So I think it's very important in terms of what are you replacing it with? Because if you're replacing it with something that kind of takes us down the same road, then we're just trading one bad thing for another. So I think part of it is, and kind of like what Anna's saying, what are you replacing it with? What's the substitute?
I would just jump in to say there's really only one metric, right? It is, how is the healthcare system performing in relationship to patients? When patients come into the healthcare system, they come in with the expectation that the whole system is going to work to lower their risk. I don't know of any patient that walks into a hospital or a physician's office and expects the system to elevate their risk, to deny them access to care. Nobody thinks about that way. Those are the only metrics that a healthcare system can use. The minute you use any other metric, you are going to create disparities. You are going to put lives at risk. And we're just fundamentally opposed to it. I don't understand. It has a purpose. Let it do its purpose. It's the same way you go to the military and you want to turn it into the Peace Corps. They would say that's out of scope. We don't do that. That's not what we do. And it's the same thing with the healthcare system. It has a purpose. Why don't we just focus on its purpose? And I think that's what patient advocates should be about, is to tell the system, focus on your purpose, right? There's nothing that ICER can do that is going to fix that, right? Because they want to ration care. They think we can't afford it. And so they can stop using quality, they can do whatever they want to do. They're always going to end up in the same place.
Yeah, and let me just close it by saying, Gunnar, that there are many essential things that people need: food, housing, energy. But we don't set up institutions in Boston to decide what's a cost-effective house, what's a cost-effective food. I mean, we just don't. Society decides these things based on the value of when it's thrown out there in the patient population, and the patients and their physicians and their families and the advocates and everybody decide, wow, this thing's wildly effective. We should pay a lot for this. Or it's not effective and we should pay a lot. Society values things with millions of people all participating in the market and deciding, you know, that this is a very valuable thing. We want more of it.
Thanks for the comments from the panelists. I want to move to the next question here. Given the argument that ICER's model and value determination is not personalized to the patient and acts as a price control, how can the true value and price of a drug be calculated in a way that reflects a patient's perspective and needs? This is a question that I have a particular interest in.
I think the challenge for our healthcare economists, the uniqueness of the healthcare marketplace is that we can't have individual transactions, that the individual can't reach into their pocket and pay for healthcare in the same way that they buy a car or a computer or whatever. And so our healthcare economists have got to figure out how we get consumer value. Because I agree with Bill, right? We are a free market system. We don't believe in price controls. We don't, I mean, they're abhorrent to us. And so we have to figure out, and I'm assuming our economists are clever enough to sort that out. How do we make sure that we value the consumer in the healthcare marketplace like we do when we go to buy cars and computers and such like, as opposed to having people dream up price controls, which we know damage our economy, don't do the job, we don't use them anyplace else, and why would we want to use them in healthcare?
The key to that, because Gary is 100% correct, and the key to doing this is to fix how the pricing system is working for drugs, get rid of the lack of transparency, and it's also, we need a better way to price innovation. And we need to change that insurance relationship, because so much of this, what we're talking about, is mitigation of risk. And Gary, I'm so glad Gary spoke so much about it, because that's what we're talking about. And we have a very inefficient way of mitigating the financial risk associated with drugs that have high innovation costs associated with them. And until we address that market, and until we get efficient pricing there, and get better pricing and more transparent pricing throughout, and get net pricing behavior and patients benefiting from the rebates. Once we fix all of this, then we're going to be able to connect the patients to their insurers to be an effective part of the demand for medicines. That's how we get value, because patients in their subjective assessments and doctors in what they've seen are able to express what value a drug is actually bringing.
I would say a couple of things to add on. One is that there is a lot of work underway. A lot of organizations and institutions are doing work to find a way to capture patient preferences better. It's work that's not done yet. So I think it's important. I mean, that sort of would be one of my closing takeaways, is the need to coordinate across anyone who's doing work in this space. The other thing is, I mean, if you're looking at value of a drug, you really, I mean, I talked about this sort of the longer term budget horizon and the short-term budget issues, but you've got to look behind that too. For chronic disease, if you really want to mitigate costs, you've got to get early diagnosis and early treatment, because that's what, for a lot of our therapeutic areas, is going to keep folks from being in the hospital and dealing with some of the issues that Gary and others have talked about. So that's where I would focus more on a holistic approach, and going back to that issue of total cost of care and then the long-term care issues.
We'll close it with one last question, and I think this one is best suited for Anna. What tools exist or are being created to help educate policymakers on the dangers of adopting ICER review and the use of quality? There are several bills that have been introduced to ban quality, but only a few are seeming to gain traction. Are advocates engaging policymakers at key policy forums or conferences? Love to know your thoughts on it.
Yeah, I think the sort of effort to coordinate among the patient and provider community and educate policymakers and others is picking up traction. I think more groups are engaged in this as time goes on, as more therapeutic areas experience ICER reviews or other reviews, as just the general concept gains more attention and traction at the state level in particular. So I think part of it is like looking at those, if not the quality, then what, how do we legitimately solve the problems that people are bringing forward in a way that isn't going to make the system, worse off in the long run. So, I mean, it's something that I think will continue along, and hopefully we'll be able to get to that point.
Thanks, Anna. And unfortunately, we're running out of time here. So, but on behalf of Pioneer Institute and the Pacific Research Institute, I want to thank everyone again for joining, and of course, our guest speakers for doing such a great job. We hope you found the conversation informing, and hope you stay engaged with the work of each of our participating organizations going forward. That concludes our program. Take care, stay well, and please continue to be engaged.
Thank you, Gunnar.